There you go, he's got it. Okay, so when you look at this page, the page 78, it shows you a whole pelvis. And what you're going to highlight on that, page is sacroiliac joint on the top. Sacroiliac joint. Oh my God, I can't even open the book. Pubic symphysis. Look at that. Look, she's all nervous. She's going by the page 50 times.
Wait a minute, what was that again?
Too late.
He said it's too late. Again, sacroiliac joint. Pubic symphysis. Pelvic brim. Because everything else is mentioned within, I don't know, in just in case, acetabulum, and the obturator foramen. That's cheap. Okay, now, knowing that, on the page, the opposite page, the page 79, will give you the characteristics of the female and the male pelvis. The main thing is you just identify, is it a male or a female? All right? So if we look at the female pelvis first, we can do the landmarks on it. So here's your sacroiliac joints. Okay? It's where the sacrum and the ilium meet. That's the one that people come in and say, oh, my hip hurts. No, that's your back. It's not your hip. So at least do me that favor after anatomy. You go anywhere, don't call this your hip. This is your hip. Hip pain is right there. Don't hurt anywhere else. Right there. That's where the joint sits. It sits in the front. Back here is back. When you hurt the sacroiliac joint, that's your back. It's related to the lumbar spine, so it relates closely, okay? So, sacroiliac joint. Pubic symphysis, where the two pubic bones meet. So if you're just asking one side, it's symphyseal surface or articular surface of the pubis. Why? Because it's not a joint yet. It's going to create a joint. Then you have pelvic brim. Fill it to the rim with brim. So it's like a rim. That's all it is. Brim, rim. Okay? It's just, you can feel it on here too. We give dance lessons tonight at the Skeletal. So here, right here's the brim. Okay? So there's the brim. So then we talked about true pelvis, false pelvis. So if I'm down in here, I'm in the true pelvis. I'm protected by the pelvic girdle. If I'm up here, I'm in the false pelvis, so I'm still in the abdomen. Okay, so that's why that's so important. Now this is a female. Why? Look at the wide angle of that pubic arch compared to the male. This is the male and the female. Look at how wide the sciatic knot space is to the sacrum compared to the male. Male's much narrow angle. Then the other easy thing, and you get a broader brim, but if you look at it from the outlet, cardiac shape versus oval shape. So there's a big difference. Okay? So that's your giveaway. Kind of this, I don't know what the hell it is, the model must have been like an old lady that they did it with, because this thing is all degenerated looking. Compared to this one's all smooth, this one's all lumpy. So, she had lumpy syndrome. Okay? So that's the difference. And they're over here, and there's a sign that says female, male. So anything that's in the middle of the room, you take it to your table and look at it, and then just do me a favor, put it back where you found it. Please don't screw it up. All right, so now as we get into the upper limb first, well, here's your scapula, right? And like I told you, if you look at the back of the scapula, if you look at this thing, we know this is a right, because it's pointing to the right. That's pointing to the right, that one's pointing to the left. So you can follow the spine of scapula, and which way direction is it flowing up towards? So pretend the acromion is like an arrow pointing to where I am. I'm a right. So there's no difficulty at all with it to figure out what are you looking at. Most of the time the bones will be laying in the anatomical correct position. You feel you have to touch it to figure it out. Like usually when you walk up to a female, I'll have a place like this on the table. Next thing I know, it's like this, why? I don't know why, but it's like this. So in other words, it's like looking down at your own leg. So it's already anatomically correct for you. If you just realize that fact, take the damn stress to no end out of you. Like people with light eyes, it's good because you can really see how big their pupils get there. Darker eyes, you can't see as much. It's like her, we'll see her pupil twice its size. She has light eyes because they're all nervous. That sympathetic system's running overtime. And you can see it. You can see it. The hands are like, yeah. So it's just you guys will see. It's nice being on that side of the table than this side. It is a nice feeling. So again, so we have supraspinous, infraspinous, fossa. And why is it good to know these names? Because when you do the muscles, supraspinatus, infraspinatus, okay? Acromion process. The most lateral part of your shoulder is the acromion. Then we have in the front the coracoid. Coracoid has a lot of things hooked to it. The biceps hooks to it, coracobrachialis hooks to it, and pec minor. So that's why it's tendon. If you follow your clavicle out and you come into the interclavicular fossa, right here there's a bump. There it is. Okay, so you're right on that. Then we have the subscapular fossa. Underneath it, like submarine, subscapular. What muscle would be here? Subscapularis. Okay, so if you learn this stuff well, it makes it easier to know your muscles when you really know your bone marks. So it does help. Okay, or you're reading a report, fractures near a certain point. You know exactly how to visualize it in your mind. All right, so there's your scapula. The other one that might challenge you a bit is the humerus. So the scapula, you're going to tell me right or left. The humerus, you're going to tell me right or left. Now, for some reason, you don't know if it's a right or left. Then just write humerus because you'll only lose a half a point. But if it happens to be a right humerus and you say left humerus, it's totally wrong because that's the wrong bone. You can argue it all you want, you're not going to win. I'm judge and jury all in one, remember that. The only time you get something that you logically can explain why you thought it was this, not on the right or left, that means you don't know it. But if you mistake a landmark for some landmark next to it and you weren't sure, that's a different argument. Okay, so there's different arguments that, yeah, you have a right to make a case, but in this case you don't. When you look at the humerus always is going to have an angle forward. So that means this is the front. So you know that if that's the front, this has to be a right humerus. The left would be the opposite of it. Okay, so when you're looking at the pictures in your book, figure out, am I looking at a right or left bone? Because people go, I don't know, this doesn't look like it's supposed to look. Because you're looking at a mirror image of it. You're not looking at a left, you're looking at a right. So it's not going to look the same. You know, it is the same, but for some reason, in your little tiny mind, you just think it's not. And it is. So here's your head. So you have the greater and lesser tubercle. Do not call them greater and lesser trochanter because it's wrong. Biggest mistake I see, people mix this up, the femur and the humerus up. They name all the parts of the femur when they're on a humerus. When they get on the femur, they name all the parts of the humerus, and they get everything wrong. There's a quick, you know, like 12, 14 points gone, depending on how many you put.
How many questions?
Oh, for you 100, everybody else 50. Probably around 60, 65 questions is where it would be.
65.
Yeah, somewhere in that ball. We get a lot of stuff. I mean, you can make it 100 with no sweat, like I do in the summer, because you only take 2 of this. Now here you have a bump. It's called the deltoid tuberosity. So I wonder what, so that'd be right here on you. I wonder what hooks into the deltoid tuberosity. Deltoid muscles. See? Rocket science, people. Then you come down here, and we have the medial epicondyle, which is big. That's your funny bone. And why is it the funny bone? What goes around it?
Median nerve.
On the nerve. Yes. Then we have the trochlea, because it looks like a trochlea with something that would, like a spindle that would wind something. And you have the capitulum. And this guy likes to touch the trochlea notch, so when it bends the elbow, it fits right in. So it makes the true hinge joint, okay? So when you dislocate it, this is what happens. When you break it, you snap that right off. Okay, so there you go. The capitulum touches the radial head. So it can rotate around it and rotate over, because it's the radius that moves, not the ulna when you do this motion. For those who don't believe me, you look at the skeletons and you play with them. That's why they're here. They're not here to, they're not Halloween to scare you, okay? They're here to learn from. It's pretty good though. You get donate your body, stay standing out in your lap for the rest of eternity. Sounds like a good job. Sounds like a good job, right? You get roof over your head instead of being in the cold ground. So then in the back you have a deep hole called the olecranon fossa, and because the olecranon process will go in it. Okay? So look at it. You don't have to tell me right or left on scapula. I mean on scapula. On oh boy, clavicle, radius, ulna, hand. No, you don't. It's just those two bones in the upper, the scapula, humerus. And we get into the lower part, femur, and the pelvic bone, coxal bone, whatever makes you happy. Just do not write hip. Femur and pelvic bone. Okay? So this has a U on it for ulna. So you shouldn't miss this. It's got the U right in it for ulna. It's telling you I'm an ulna. And that would be the trochlear notch. And this is the olecranon process. And there's the ulnar styloid, which helps stabilize the wrist. We look at the radius. Unfortunately, don't have an arm on it for radius, but it has a head and a styloid. And that's all you need to know about it. So you really don't have to go freak out like you like to do. This is easy too. Clavicle, then what end? What end is this? That's in my fingers. What end do you think that is? I'm going to say sternum.
That's the wrong word, but it's the right position.
Chromian end, not sternal end. Because if it was sternal end, it wouldn't fit right. You'd have a big bump over here, right? So you'd have this. So the one that runs perpendicular is the sternal end. The one that runs horizontal is the chromial end. All right. All you need to know on the wrist: scaphoid, lunate. That's it. There's no you have 8 of them, but scaphoid, lunate. That's it. Scaphoid, lunate. Then you count from the thumb over. 1, 2, 3, 4, 5. So these are your metacarpals. These are your phalanges. The thumb only has 2 parts to it. When you get to the phalange of the thumb. Proximal, distal. This has a proximal, middle, distal. So if I put a sticky here, how would you name this?
Number 3, middle.
Third middle phalanx, right? Number 3. How about this one? Go ahead, number 5. Proximal. So 5th proximal.
Halachis.
No, that's not there. You got that wrong. No, that's over here. What's the pinky? So that would be 5th proximal phalanx. If we're here, it'd be first proximal. No, distal. Okay, do you understand the nomenclature? All right, got it. We're in good shape then. A friendly bone. So how do I know this is a right versus a left? Well, if I hold it this way, and my thumb can tuck underneath the spine of ischium, then I got it in the right hand, so it's a right. Because if I put it in my left hand, my thumb's got nothing to touch. So I know this can't be a left. It has to be a right. So those who have a left, pick it up and put it in your left hand the way I'm holding this thing, and you'll see, you'll tuck it up. Your thumb will tuck up under your left, just like a little bit. All right, so now let's look at this thing and break it apart. 3 bones come together to form this. They unite in the acetabuli. So up here's the ilium, the pubes, the ischium. Okay? Let's do ischium first. It's easy. So we have ischial spine, ischial tuberosity. This is what you sit on. The ischial tuberosities. So stop thinking with that. Okay? This. Ischial tuberosity. We have a big hole here called obturator foramen. And they unite, I told you, in the acetabulum. And what would go in the acetabulum? Right. Thank you. So now let's go to the front. Well, right here's your pubic tubercle. This is the symphyseal surface or articular surface of pubic bone. This is the tubercle. And this would be the anterior superior iliac spine. Can somebody give me one of those sticks, please? Thank you. So we take the stick and we put it from here to here. Well, this line I've created on here now is the inguinal ligament or canal. And the significance of it, just for purposes of landmark, is when I cross that line, I'm no longer in the pelvis, I'm now in the lower extremity. So that's your guiding line to know that. So when you're following a nerve, an artery, a vein, you know you're no longer in the pelvic region, you're now in the lower extremity.
What's that called again?
The inguinal canal. Okay, so now let's come up here and do the ilium. So this is the crest. The whole thing is the crest. And in the front, like I said, you have the anterior superior iliac spine, which you can abbreviate as ASIS. On the back, you have posterior superior iliac spine, which you can abbreviate as PSIS, like it is in your handout. On the side right here, you have the pubic tubercle. It's the bump that sticks off the crest, right here. You can feel it on yourself. It's right here. Okay, it's roughly about a little over an inch up from the ASIS. There you are, as you come up your crest. Okay? Then we come here, we have the greater sciatic notch. I wonder what goes through that. Sciatic nerve. And the auricle, the auricular surface, because it looks like an auricle, your ear. That's what it looks like. And it touches the sacrum, hence forms the sacroiliac joint. Okay, I think that's all the parts of this thing that you have to know. So, there you go. Femur, pretty easy. Femur always has a forward bend to it. That's the front of it. And it's smooth in the front, rough in the back. Okay, so here's the front, so we know that's a right. So we have the head, neck, greater and lesser trochanter. The jagged, rough line, the linear aspera. Then you have condyles, these rounded articular surfaces that form the knee joint. The medial lateral condyle, patella surface. This is what goes there, the patella. Like this. Inferior pole goes just like that, and it slides up and down. And the patella is what? There you go, largest sesamoid bone in the body. Very good. The only two things I really want you to focus on the tibia is tibial tuberosity, medial malleolus. You don't have to worry about the condyles. Okay, because this would go on here like this. See? And if you didn't have that patella, look when you flex your knee, how vulnerable that joint would be for something to go right into it and just destroy the capsule. Okay? That's why you have a patella, to protect it. So why is that important to know?
Because that's where something comes out.
Well, the patella tendon hooks on it. And it likes to avulse this thing. Remember, we talked about Osgood-Schlatter disease, right? So it's something that you probably would come across somewhere in your nursing career. So what's this known as? We said this was an epiphysis, diaphysis. So what's this known as?
Epiphyseal notch.
Oh, APO, apophysis. Remember that? Apophysis. I would know the existence of this word since I mentioned it in the lecture and I mentioned it here. That's known as a secondary throat plate. There you go. We have an apophysis right here. Okay? So why is this such a big deal, the medial malleolus? Because it's going to form the ankle mortise joint. And what would be on the outside of it? The lateral malleolus. So that brings us to Cupid's arrow, being it's, I'm going to say Halloween's coming to me. Valentine's Day. Damn, I forgot a card yet. I got to get my ass to this. Oh, no! So what kind of fracture would this be? There you go.
I was going to
It's
say,
supposed to be
like,
plastic and flexible, but it's not.
Valentine's Day gets you really mad, huh?
I'll get another one for you. But the lateral malleoli versus the head is flat. The lateral malleoli is more pointy compared to the head. So the pointier structure that breaks off is the...
You gonna tape it?
Yeah, I'll tape it.
Why we don't have, we can't.
I'll just chuck it out. We got a ton of these. Huh? The head. All right, so in the lateral malleoli, I'll get you in a minute. The lateral malleoli is the one that's, and is how you heal the fracture. So what would come in here to do this? What's taking place first when it first breaks? The what? We set it, and then what's going to happen after that, then what comes in beyond it? Osteoclast comes first, right, to gap this fracture. See, things break here.
Would you like this?
Huh?
You want to split it?
No, I don't want to glue it. No, because I'm going to chop this. We'll just throw it. Because you're going to draw full of it. I'll get you. But there you go. So when you look down it, there's the pointy and there's the flat. So it's like a broken arrow. Right?
Hey, do you want to touch this fracture?
Sewn by, yeah, you ever see somebody with a flat head? There you go, flat head. Right? And it's pointy at the lateral malleolus. In the foot, you don't get tested on the whole foot. Can I have these two bones? You get tested on the talus and calcaneus sacrum. There's your talus, which forms the ankle. Here's the calcaneus, which forms the heel. All right, so they'll be that way before you want to test. I do not put the whole foot out because it's easy that way. How many tarsal bones do we have? 7. Very good. 7. Somebody does it. What are these two things in here? You know what they are? That's what I'm asking you. What do you think they are? They're showing you representations of sesamoid bones on this one. That's where they would be on this joint, protecting the undersurface, so nothing would come up into it. And on the lateral surface of his thumb, they're right in this area here. So you can see them on an x-ray, it's not a fracture like that. Okay? But I'll get you a new one, because I don't want you to feel you got gypped and it's broken. All right? In the front of the room, when he was picking up, this is what osteogenic sarcoma did to a female. So this person was probably only a teenager.
That's real? That's
And it destroyed it.
That's real?
No, it's a casting of a real one. Real one would cost a fortune to get this. So they probably amputated, so it looks totally gone. The head's obliterated, all that's gone. All right, so there's that big sunburst lesion you would see on the x-ray. And look at the lytic lesions at the end, how it's eating the bone away. So this looks like the bone is literally melting itself. And the osteoblasts try to come in. So in this person, man, you'd have, alkaline phosphatase to the roof on enzyme studies. Because you have so much lytic reaction taking place on the bone. So that'd be unbelievable. Here we have all fractures that heal the deformity. And this humerus, look at this clavicle. Wow. You know, so look at the scapula. It's not going to work too good. Look at that glenoid cavity. It's crushed, really. So I mean, it's not going to have much action. And here's this fibula, and look at my alignment, much better. And then these vertebrae show you what arthritis looks like. Look at the spur formation coming off this. So these are real. These 3 are real. So this was, so respected.